Good morning to everyone. Welcome to everyone. And thank you for joining this interactive webinar on the SMART guidelines for ESAVI surveillance national systems. I'd like to remind you that you will have access to interpretation from Portuguese, into Portuguese and into English.
Welcome everyone to this SMART guidelines for ESAVI surveillance webinar. We remind you that in your controls in the lower part of the screen, you will have interpretation from Spanish to English and also to Portuguese.
Today's agenda is a very full one, and the purpose of this event is to present the SMART guidelines for the development of surveillance, SAVI surveillance, and to share a draft of the digital adaptation kits. So we hope those responsible for SAVI surveillance to help us accelerate the process of the development of useful tools for the surveillance purposes, and to socialize the exchange of ESAVI data and develop the FHR, fast healthcare interoperability resources. We will begin with the introduction of Dr. Daniel Salas, the General Manager of the Central Office of PAHO in Washington, Dr. Marta Belania, immunization advisor, who will speak some opening words, and we will continue with the importance of standardization of ESAVIs and their interoperability by Dr. Mainz, leads up our center in Chile, the National Center for Interoperability. Then will come the presentation on SMART guidelines of ESAVIs by Dr. Daniel Lisato, who is the manager of the SMART guidelines for the Pan American Health Organization at headquarters. And we will also then have a presentation by the components of these, about the components of the SMART guidelines. We'll review each one of the components, and we will review and have a space for interaction, a written interaction only, where you will have the opportunity to place your questions in the chat and in a form that we have designed for this purpose. The idea is to hear and see your input. We would like to clarify that the guidelines that you will be seeing are only a draft of the final version, which the experts and heads of what we'd like to hear is your feedback on these guidelines, so that, as we always do with the PAHO documents, which are always developed in a collaborative fashion, because we want to have the best document possible to help the countries in the region. So without any further ado, let's move on to the first point. I now call on Dr. Daniel Salas for some opening words. Thank you, Felipe. Thank you very much.
As a reminder, you can select the language that best suits you in the interpretation icon that is in the bottom bar of your screen. You can select either English, Portuguese, or Spanish, just as a reminder.
Thank you very much for joining us today in this very important webinar. As you know, the surveillance of ESAVIs, events supposedly attributable to vaccination, known as ESAVI, is a very important pillar for immunization programs. There's also the key interest by regulatory agencies in pharmacovigilance. But for immunization programs, it's extremely important because it allows us to provide transparency. It's very important when there are doubts about what's going on an event that is suspected to be attributed to vaccination. We should be able to inform and report and show that our systems are not hiding, are not ignoring this very important point in order to generate trust and confidence that we want the population to have about immunization so that they can understand that vaccination is a very clear benefit compared to these events, which we know most of which are only temporary, leave no side effects. And although, yes, there are some that might be acute, but they're very, very rare. So it's very important to establish that causality. That's why it's very important. And we know that during COVID-19, it was important to have constant surveillance of ESAVI, although it was clear before that this existed, but we had not pushed it. After COVID-19, the pandemic made ESAVI surveillance extremely important, and we realized we had to expand it in the event there's a new catastrophe. Also, it's very important to do that monitoring during emergencies. We have different emergencies that we've had, for instance, with mpox, and now with the multiple outbreaks of measles, where there is the need for countries to analyze the use of the measles MRS vaccine to control the vaccine outbreaks and through vaccine. So it's very important to have this constant monitoring of ESAVIs. It's also important that we deal with new challenges, and often we have to deal with new populations. For instance, they're in yellow fever, there's some outbreaks that are occurring, and we need to make sure that there are no ESAVIs, and there's a need to assess the risk benefit of vaccinating people who are over 60 years of age, although we've mentioned that children over the age of 10 that are not recommended to have the vaccine of SRP. So it's very important to have surveillance using digital tools. When we have a surveillance system that has quality information, it not only reduces the burden of work for the national teams, but it also makes it easier to generate information to make quick decisions. You don't have to go through a very lengthy process, which in the past was a very manual, slow process. Now, in few minutes, even seconds, we have predesigned outcomes, and we can make decisions. Also, we need to speak about the SMART guidelines of WHO. This model of SMART guidelines developed by WHO is a very powerful tool that allows us to quickly resolve a problem using digital tools. It supports our services and supports the surveillance of public health. So now we're going to find out why these guidelines are so relevant and so appropriate for this topic. We also need to mention the use of resources and data. Currently, as public health surveillance must be done without the support of digital tools. We know that with digital tools, even though resources are limited in public health, we need to find how to maximize them and make them more efficient, because there are many topics that are competing with immunization for our regulatory authorities, and we have to be very efficient in addition to providing quality. It allows us to raise the level of quality of everything we're doing. So your participation in this is key. One of the first SMART guidelines developed in the Americas is this one, and it's very important to have your feedback and your recommendations so that together we can improve surveillance and the safety of vaccines in our country. So we hope that once these guidelines are published, we will be able to speed up the development and implementation of these effective tools that will make the work of everyone involved in ESAVI surveillance easier from the local community level to the national federal level. So thank you very much, and we wish you the best of success in the rest of this seminar. Thank you very much, Dr. Salas, for your words, motivating words. And now I will call on Marta Belanda, our regional advisor, to provide information on immunizations. Good morning to everyone, and thank you for being here with us in this joint effort. This is only part of the path we have to uh, go through jointly in building better information systems that can become standardized. I think that's one of the main advantages of using SMART guidelines. We will end up having a standard that all of us will be able to work off, and we will work therefore all in the same way. It'll allow us to ensure that information systems can be digitalized, and it's very helpful. We need it's something very important with SMART guidelines is to be able to have your volume has gone down significantly. You started out okay, but the volume dropped significantly. Let me give me a minute. I'm going to put my earphones on.
Creo que es Zoom que automáticamente baja el...
Un segundo pongo el micrófono, perdón por eso.
Much better.
Ahora. Bueno,
as I was saying, this is a path that we want to work on jointly, and you are invited to participate in this effort. As I was saying, that by having a SMART guideline, it makes it easier to have one standardized process and all be on the same wavelength. When we say user, we know exactly what users we're talking about. It's those that have been established in the SMART guidelines. So your participation and your help in continuing in this effort is very important. So we need your support in order to move forward. Our intention is that by using these SMART guidelines, we will be able to have a local adaptation. It doesn't mean that SMART guidelines are once and forever, but rather that we can adapt it to each of the information systems of your countries. Obviously, it will also make it easier to make decisions in your countries, and will provide for continuous upgrading. As I said earlier, in this effort to digitally transform immunization and help us have single systems and data that allows us to identify who has been left behind so that nobody's left behind during the immunization process. So thank you very much for being with us during this session. Thank you, Marta.
Muchas gracias, Marta,
for your motivating speech, encouraging us to work jointly. I now will call on Dr. Mai Tumali, who will give the first presentation on the importance of standardizing ESAVIs and its interoperability. Remember that at the top of your screen, you can choose the language in which you wish to hear the presentation. You can choose between Spanish, which is what the speaker will be speaking, or in English for the interpretation. May, you have the floor. Thank you very much for the work done by the team. Very important. I'd like to begin with some thoughts on the importance of standardizing ESAVI and its interoperability. We lost her sound. What I did want to say is speak about the need towards developing interoperable records in the area of vaccines. In a world that is much more globalized and where information is required more quickly, we need to have access to a greater volume of information. And there is no doubt that this is very important need. That's why we decided to organize this webinar and speak about how the guidelines can help us. I'm not going to define what ESAVI is because you're all specialists in it. But surveillance is key for three important reasons. First, it ensures the safety of vaccines, it protects public trust about vaccines, and a more relevant point is that these helps us guide our regulatory framework and epidemiological decisions. And we can only do that if we have quality information. The it's more technical, but it helps guide epidemiological decisions because they require very precise and timely information. The challenges that we have at the moment in the current ESAVI surveillance systems is that we have duplicate or incomplete records. There are inconsistencies in clinical language and terms. There's a delay in reporting. There's a lack of traceability of a case throughout the journey of the patient suffering from an ESAVI, and often there's incompatibility between technological platforms. These challenges, therefore, require a standardization, and that's what the organization is proposing to do through the development of these SMART guidelines that are under construction at the moment. So what do we mean by standardize? Standardize has to do with two areas of action, the semantics and the syntactics. What is the vocabulary that we use? What are the common clinical definitions? And then syntactic, how you say it. What language do you use at the national level? So it's the use basically of common clinical definitions, terminologies, and classifications that allow us to speak the same clinical and technical language, and maybe not just speak, but also read the same clinical and technical language. For those people who have to analyze a specific case, either at the national, regional, or global, supranational level. Let me give you an example. Say a child that has a post-immunization seizure. So the question then is, how is it recorded? Is it a neurological reaction? Is it a mild adverse effect? Is it a febrile seizure, convulsion? What? Etc. This causes us to lose the ability to identify patterns and effectively use information.
This is the proposal that we've brought forward because we believe this to be necessary, and I'm referring to standardization. On the other hand, what are we talking about when we talk about interoperability? We speak of interoperability as the capacity that different systems and organizations have to exchange information in real time and in a common language. We may not have a language that is common to all of us, but we do have this set up for a common language. It allows us the ability to engage with different systems and organizations to exchange data and information in real time. It allows for better tracking of individual cases, improved interpretation of case patterns, and reduced case entry errors, and therefore improved information quality. Now, what do we gain, or what impact does this bring about? Well, we're going to have reliable and comparable data, greater efficiency in management, improvement in clinical and public health decision making, faster identification of warning signs, strengthening trust in vaccination programs. And nowadays, since third parties are attacking the immunization framework, we can come up with more reliable information. We can create faster responses to serious adverse events, population level analysis capability with accuracy and precision, better criteria to adapt schemes or strategies, and reduce risks associated with interpretation errors. This is also a great impact for public health because by improving surveillance, then we can bring about, as I mentioned, faster, more effective responses. We can create national alerts. We can deal with different outbreaks, pandemics in different locations. From the public health standpoint, This interoperability offers all of these beneficial impacts that are extremely necessary, especially in an environment that is so disorganized as it is at the present time. Now, any digital transformation challenge requires knowing what the gaps are. And these gaps can have multiple dimensions. And when we talk about applications and improvements for digital transformation, we need to be able to assess all the existing gaps. And this allows us to move towards clinical teams that use electronic and structured records, IT teams that can design and implement interoperable systems, health teams that are adequately trained in the use of classifications and coding, surveillance teams that have data enabling them to generate quality information, pharmacovigilance teams that can identify risks and produce clinical evaluations and assessments, and decision makers who define international standards to be used and promote laws and/or agreements between institutions to share data. Standardization allows us to understand this is what this calls for. Interoperability allows for action. It's an effective surveillance of ESAVI, and this is something that requires both. It's not just technology, it's public health. So we need both aspects. And again, as I said, this is not just technology, this is public health. We are trying to set up an enhanced system that will allow us to make better decisions for the benefit of the population that we serve. Thank you very much. Thank you very much, Mai,
Gracias, Mai.
and thank you for your final insights. Let's move on to the next presentation. The next presenter is Dr. Daniel Risato. Let me just share my screen. Go ahead, Daniel, please. Thank you very much, Felipe. Can you all hear me? Yes, we can. Thank you. After the inspiring opening remarks from Director Salas and Dr. Marta Velandia and all of this context provided by our colleague, Mai, in order to be able to embark on this SMART Guidelines project, it falls to me to discuss the SMART guidelines that are being adopted by the World Health Organization. We could try to come up with a literal interpretation of this, but SMART is also an acronym that seeks to include some additional characteristics for these guidelines that have the purpose of digitizing recommendations issued by WHO and PAHO and do so in a much more effective way compared to prior attempts. Now, we all know what the function of these organizations is, and that is to issue health recommendations. This is done through systematic revisions of the most recent scientific information to be able to make clinical decisions or pharmacovigilance epidemiological decisions, such as ESAVI, and this is usually shared in the form of documentation. Previously, we would have monographs or projects that were taken physically to different countries, and that was subsequently digitalized or digitized into an ebook that can be sent via email or uploaded to a website. But this is still something that people have to be able to read and interpret. And naturally, each country receives these recommendations that are validated through events such as today's event, such as literature reviews and adaptation. But in order for the implementation to take place in such a way that there will be an impact to patients, each country comes up with a national guideline. In our case, it could be a national guideline or a manual, a user's manual, that can be global or regional. Each country can adapt the guidelines based on their local context. Nowadays, in the 21st century, everything is undergoing a digitizing process, and many countries are trying to digitize their healthcare practices and management practices, especially in public health. So many of these guidelines try to incorporate in or integrate into these systems, and each system, be it local or if it's an open code system, needs to incorporate these recommendations. But for that purpose, they need to be able to interpret the information. Such as, for example, for this PDF file, I'm going to come up with a digital form. And for these recommendations that I see in a paper form, I'm going to integrate this into my digital form. This subsequently has to be conveyed to the healthcare team with the adequate training so that the information can have a real impact on outcomes for patients, and the outcome can be expedited in the most efficient way possible. So what does this involve as far as the countries are concerned? So what we're trying to achieve with these SMART guidelines is to facilitate this adoption process with this new approach. And this is something that's based in evidence and standards, but it contains reusable components that will allow countries to use their own components, but through this set of guidelines directed at immunizations or what have you, can be adapted to the following case. And this has a great deal to do with the fact that we have many fields that we delve into, and we see many different forms, and a lot of them are redundant. We have pharmacovigilance forms and documents, and they are sometimes similar to ESAVI forms and documentation, and there are many forms that share some common features. So the idea behind the SMART guidelines is to come up with this new approach to be able to address these issues. And each country, depending on their level of digitation or digitization, can adapt and adopt their systems to these new standards and guidelines for interoperability in such a way that in various sectors they'll be able to capitalize on all of the components. In other cases, they can capitalize on the new approaches to enhance their systems. So we see this dual impact that's already been mentioned. We want to understand what needs to be understood and make informed decisions based on that interpretation and understanding. So what are these 5 progressive levels that the WHO is promoting for this progressive evolution? The first is to take on the narrative component. We have to review the existing model with certain enhancements. We do know that in the ESAVI manual, we did some updating during the COVID pandemic, especially as they related to the new vaccines that were developed at the time. And in some way, we need to be able to identify and specify how these practices will be used in following steps with the necessary inputs to move on to stage 2, which is the operational component. And this is where we prepare to go digital. If we speak to the systems people, or if you had any type of participation in this type of project, you can understand that we need to know what we need, how we want it to be presented, what we need to conclude, who are the users for the system, what process or what workflow will be integrated into the system, what enhancements will be required for the system. All of these things that to date involve the implementation at the country level. And so when we come up with these specific digitization guidelines, then one can simply adopt these practices and a great deal of the work will be done. So there may be an additional adaptation process at the local level, but when you adopt these guidelines, you'll be 80% towards your destination. Now, the next stage is machine readable documentation. I don't want to bore you with too many terms in the jargon, but the idea is that any system that uses these recommendations, these guidelines, and these forms, once the decision was made to create a form for entering data, be it for initial notification or research, if you had a common system, then you could generate the electronic form within the compatible system and moving it forward using this standard. This would be level 3. So it's one more step in the evolution of incorporating the necessary specifications to the system. Now, what is level 4? Well, these are systems that have these characteristics. These need to be systems that have to be able to be adapted at the country level or institution level. And so when I show up with the technical recipe book for level 3, then we could ask for an institution or a country to show me the form that they want to integrate. We do have systems in different parts of the world that are implementing many of these things. We have one in Peru, for example, that relates to the SMART guidelines for immunizations. And in order for us to be able to apply all of this digitization, we adopted this open code, which is mobile, whereby the guidelines or the immunization recommendations can be integrated into that particular local system. And lastly, level 5, with all of this standardized information, which is also digitized, we can begin to embark on the effective decision making and analytical work to be able to make precise decisions. Now, we understand that if we enhance each one of these steps, we will then end up with better information, which will lead to better decisions that are not only evidence-based, but are based on this standardized framework. Now, so far, we've been talking in general terms about these guidelines. But when we talk about ESAVI-SMART guidelines, apologies, the audio has been interrupted. Daniel. PAHO, in our case, can start by creating the guidelines. We made an agreement with the SENS to bring on their technical expertise to provide support to all of the users. Daniel, we're losing your audio. Your signal, your internet signal is having issues. Daniel, I'm sorry, Daniel. I think that you need to shut off your camera to see if your internet will improve because your audio is intermittent. Go ahead. So, as I was saying, the creation process is something that we do at the regional or global level, be it by WHO or PAHO, and we're trying to move forward with this digitization effort, and we want to be able to set up a template for each one of these components in order for countries, in accordance to their needs and capabilities, can adapt these to their local needs. So much in the same way as we established an ESAVI manual that each country could adapt to their own specific local needs, the same thing would happen with specifying the requirements for the adaptation kit at level 2, and each country needs to decide for themselves whether or not these are the specifications that they want for their own systems or whether they will make different adaptations at the local level. The same thing happens with level 3 activities as well as level 4 activities. If you're looking to adopt a new system, or if you're looking to retrofit your existing system in such a way that they will be more compatible with these guidelines and standards, then you can do so. Now, we do have PAHO and WHO, as well as their partners, providing support to the various countries to be able to make these adaptations with technical guidelines as well as other guidelines that are in play. As far as scenarios for use, we mentioned that countries may or may not have a certain degree of digitization already in place. It depends on each country, and each country would then have to follow their own digitization strategies, especially related to public health. There are medium and long-term goals for this. The audio has been again interrupted. Apologies, but the audio has been interrupted. Daniel, we lost you again for a few seconds. I think we have just 2 or 3 slides left, so please go ahead. So the idea is for us to understand that each country, regardless of their level of digitization, can still capitalize on these guidelines. Just as an example, those countries that don't have installed digital systems, say for ESAVI pharmacovigilance, they can still use these SMART guidelines in their narrative form, but also those that are currently included in the digital adaptation kit. So they can identify potential future systems that they may want to adopt. And in those countries that have existing systems, they can adapt them to the standards of the WHO or PAHO. And they could also adopt different practices and standards to define the name of a disease or a vaccine. Next slide. Just to mention this, because we're going to be talking about this in the webinar. In level 2, which is going to be the topic for today, you have to have certain requirements, and you'll see that there are 8 components that are very important for this digitization effort. And we would talk about those recommendations and the narrative sources that will serve as the orientation for this digitization. We're going to talk about generic persons or users.
What are the user scenarios that will be developed in the system? What are the workflows for each one of them? And the main data elements like the dictionary, data dictionary for the system. Here we'll compare the data of the system I currently have with the data dictionary that is being proposed as the gold standard, as the ideal by PAHO. Also, specific rules for supporting decision making, for instance, to determine whether a case is acute or not, serious or not, based on several variables that appear in the form. Also, specific indicators that will allow me to decide whether I'm moving ahead properly in surveillance or not. Some are more operational, but some are also metrics indicators, the number of cases I have, the type of cases, is it serious or not, acute or not. And finally, functional and non-functional points, which together with all the others will help the developers or the company that is supporting this component to define what the system will be. Next slide, please. Next slide, please. And also to tell you that in ESAVI, we began this project mid last year. Obviously, it was a competitive bidding process between different partners, and together with Sense, in November 2024, we began to develop a work plan and the first digital implementation. Since December until mid this year, it was worked on an iterative basis, both on component 1 and 3, and we finally came up with the version that we're sharing with you today in this workshop. And the idea is now to hear your feedback so that we can develop the digital adaptation guide and final comments by you to prepare a final version. Obviously, this material is useful if you're working on this, but it will require a formal process before it is officially published by PAHO. And next slide, please. And as we not only work with SENS and specialists of PAHO with weekly meetings and weekly follow-up and asynchronic review of the different documents, as you will be doing, but also working with the World Health Organization and the digital surveillance group, which is working on the smart lines on surveillance, which has not yet been published. Just as we prepared this smart guideline for ESAVI, there are many others that are being developed in each one of the health and public health vertical lines that PAHO has, so that digitalization becomes easier for most or all countries in each one of the areas for which there are recommendations. And finally, we have come to this workshop to hear your feedback and improve the standards. That is all. Thank you very much. And I wish you the best of success in this effort. Thank you, Daniel, for the presentation and the introduction. I think we have a very clear picture now of what the SMART guidelines are all about. For those of you who were not familiar with them, that was one of the goals of this meeting. I now would like to remind you to place your questions in the chat. Unfortunately, because of a lack of time, we won't be able to open our microphones for interaction, but we will respond to you, questions asked in the chat, and then we will describe the process of the review and implementation of level 2 components, which we'll be presenting today. Let me now call on the next speaker. We will now get into the very content of these SMART guidelines. We'll review each one of the components. This is a component that is of interest to those who are responsible for ESAVI surveillance, as well as the people who are developing the digital tools. It serves as a bridge between those who work on surveillance and those who are developing the digital tools to support the surveillance process. Let me now call on Francisco Ñasco, who is a sense engineer, the collaborating center, so that he can present to us all the components and explain their content and some of the recommendations that are included there. Francisco? Can you hear me? But we don't see your presentation yet. Give me a minute. Yep, it's up there. Good morning, everyone. I think this work has been very gratifying and interesting, and I hope that you now will be able to participate in this last stage. Your feedback is very important. The presentation now will be longer. I am giving a presentation on the main topic, but will be supplemented by comments from other members of the team. So overall, as Daniel mentioned, the SMART guidelines have different components to them. In this phase, what we will do is present a general overview, kind of reviewing what Daniel presented, and then we will move on to the full explanation and the review of each one of the components. This is the L2 review, the digital adaptation kit, and then I will briefly look at level 3, which is more the implementation. It's more technical and less flexible, but what's important is that we focus on the digital adaptation kit, the L2 review. Daniel had already mentioned some of the characteristics of the SMART guidelines. it's a compilation of all the background information, all the problems and challenges encountered at the clinical level and caring for the patient, all the way down to the operational level, where we then translated all these requirements, all the needs for health interventions, and moved it to a structure which is becoming more and more technical. Then we moved on to level 3, as it appears here on the diagram. Level 3 has a very technical component to it. It's a definition of transactions, of terminology, of standards that serves and helps to implement what was already defined in level 2. And then in level 4, we will move on to the applications, the implementation. And of course, they have to be based on level 3. That's how we move forward until we finally reach level 5, the dynamic level, where a much more in-depth analysis of the data takes place, including using artificial intelligence, detecting patterns, etc. All of this, as you see, will benefit not only the patient care, but also it'll reduce the amount of time and spent in collecting information to correctly treat a patient. It also accelerates the digitization process and all the benefits that brings, not only for those who define the guidelines, but also for the technical staff. It's much less waste of time, because now we will have a structure that will tell you how to work from functioning, from operations to the practical aspect, from the theoretical to the practical. So that's what can be done through the use of SMART guidelines. Now, level 2 of the SMART guidelines is the digital adaptation kit. As we said earlier, it has 8 components to it. The first defines a technical documentation, and it moves on to the health interventions and recommendations. Then component number 2 is the generic people, and we will work more on this technical side. Following that, we will look at component number 3, which is the user scenarios. These are narratives that tell you how to carry out the flow of care in the event of an ESAVI at the different levels, from the more institutional perspective at the level of the health institutions down to the very functional level. And it also graphs the work process. As you can see, this will deal more and more with technical levels that will allow for easy translation from the language of business to the language of the systems. Then we move on to component number 5, which is key data elements. That is the group of data that we need to handle within our system. This is a phase that doesn't require much effort to develop the software, because it provides with a series of very clear data, how you treat the data, which ones will be included, which data will be managed in a scheduled manner. In other words, every certain amount of time that certain data is processed and calculated, etc., what kind of filters you'll use. And then you have the component 6, which is the decision logic support. And this is what is the logic that should be reflected in an application. For instance, when do you need to move to the next level of processing in a ESAVI case? Or is there data missing? What needs to be done if in the event data is missing? That's all under component number 6. Number 7 is performance indicators and metrics. It allows you to generate insight for decision making and tell you what's going on with an ESAVI. And then component number 8 are the high-level functional and non-functional requirements, which is the most technical aspect. It defines the rules of the game of an app. So the idea here is to go component by component. I'm not going to try to require extreme concentration. I'll try to go through each point one by one so you can understand the idea in general and then provide feedback once you read the documents and you understand this the presentation. It's this the purpose of this presentation is to introduce every element so that when you read it yourself it'll be easier. So component number one is health interventions and recommendations. This serves as the link between the narrative that already exists within PAHO's various tools. There's one tool called Universal Health Coverage, which is a catalog of all health interventions done by PAHO and WHO. And then under that, or within that, UHCC, what we see is that the interventions that have to do with surveillance are mainly vaccinations. So it's one component under all the practices recommended for vaccination purposes. There's a lot under this. However, this guideline focuses only on surveillance of ESAVIs. It's just one point under this UHCC. However, PAHO and WHO have documents that establish the structure for how to invest, how to organize, and develop your digital systems. And under that, we found that there are several points. If you look at the left-hand DHI category column, digital health interventions, DHI, you'll see that there are 4 main points with a few additional points that denote the importance of ESAVI surveillance and of the importance of digitizing the process. So even though it may have been mentioned earlier, here you can see a better definition of why it's important to develop these SMART guidelines and the ESAVI surveillance system. In the same document, you will also find a catalog of all the documents that serve as the basic scientific reason established by PAHO. It is the raison d'etre for these SMART guidelines. I'd like to highlight the importance of the manual guideline on ESAVI surveillance, which is the foundation, the basis. It has a lot of the rules of the game, and they appear in this patient kit as well. Then component number 2 are the generic people. We have defined here the users of the system, and we define the role of each user. And for this, we define 2 types of people: key people and related people. Key people are the ones that define the roles of the people that will directly interact with the system. These are the people that provide ESAVI care and process the information. So there are 3 levels of these key persons. You have the institutional level of key persons, and here we define the roles that exist within a health center, vaccination center, or hospital. And then you have what are the roles that need to exist at the subnational level. These are what we define as districts, federal, communal, state, zonal organizations, or groupings within the next level. In other words, those who coordinate the various health centers, whether it's ambulatory hospitals, etc. And then you have the national level, the ministerial or nationwide level of policies. So the key persons at the institutional level, we have 2 defined: a primary notifier and an institutional ESAVI surveillance focal point. The idea is to have at least one person who will have all the knowledge and prior training to be able to properly notify an ESAVI occurrence, and the data about the patient, the vaccine, etc. And then it has a higher level within the institution and is able to supervise the work and serve as the person that ensures that the data does reflect the reality of the problem. And then you have the subnational level. Here you have the ESAVI researcher, and their role is to collect more details when an ESAVI requires, a serious ESAVI occurs, for instance, or meet certain characteristics of national interest that have been defined by the authorities, then this person does much more in-depth research, and that research has to be coordinated and led by the researchers. Then you also have the subnational reference for ESAVI surveillance. This person has the role of supervising the research process and any related process. Then at the national level, you need to have persons with additional specialization. For instance, the national reference that mentioned above, the national reference of the national and the expanded immunization program for the surveillance, the national pharmacovigilance reference for vaccines, and national pharmacovigilance center. In addition, there should be a data analyst whose mission and job is to discover what is behind the data, discover, for instance, behavior patterns or trends, provide evidence of certain data or relationship between people or events. Then you have the National Safe Vaccination Authority, are the ones that finally organize the information and determine how to classify the case. So here you see the full set of persons related to the key persons that participate within the ESAVI process. This is, of course, is an ideal system. Now, but we realize that there are many different realities, different systems, but this is what we consider to be the ideal situation based on PAHO's experience. Now, the structure by which these key people are represented in the document is through a title and a description of other names that help define these definitions and attach them to reality. It helps establish the standards that need to be used in this identification process. Here, for instance, as an example, you have the occupational title, which is a primary notifier of ESAVI. It's a person who records the data of a new ESAVI and reports it to the vaccinator, doctor, nurse, etc., at a higher level. And this can be a healthcare professional who can record the pharmacist, caregiver, patient information, etc. In the event the country has greater digitization, then the notifier person could be not necessarily does have to be a health professional, but and we'd like to emphasize this, when you're first doing this, when you're implementing a surveillance system, the ideal is that it be a trained professional to ensure that the quality of the data is good. Here, in this scenario, you have some roles that are oriented more towards direct care of the patient, for instance, the vaccinator, doctor, physician, etc.
So people related to and identify as part of the process are those people that don't have direct intervention with the system, but that do participate in the information flow. So the data entry operator will not take part in the decision-making process in the system, but whoever's at the desk working on entering the data into the system still has a corresponding role. Same thing applies to caregivers and patients. Perhaps a person might have a reaction, or there's a suspicion of a reaction that this is something that could be a possible adverse event from immunization. And that would also be an important role. So these are the first two components, and now I'll yield the floor to Felix so that he can talk a little bit about the feedback and how we should proceed with this program. Thank you, Juan Francisco. I'm Felix Liberón. I'm the Executive Director of SAMS. We are very happy to be working towards the final stages of this process. And as Juan Francisco said, this is very important, and it has also allowed us to co-build this framework with some partners. Now, we've shared something in the chat, two things. On the one hand, we have the forms for which we would hope we can get some feedback from you. And you also have a folder with the different materials that we've been talking about from the outset today, starting with Juan Francisco's presentation. And it includes other documents, such as the one that we're discussing right now, the digital adaptation kit, in order for you to be able to delve more deeply into these issues. And the idea in general here, and you can tell me if you see any change in the shared screen here.
Sí.
Yes, we can. So we want to make available a form that is very simple and easy to use, and that we hope will be very useful to enhance and identify different gaps that we will be improving on. And we want to also use this for the assessment of the different components addressed by Juan Francisco. Now, for those of you who have access to the chat, you can access these documents. This is a form, a document that will be available throughout the course of the webinar. And for the next 2 weeks, for those of you who don't feel comfortable answering the questions that we are asking here, regardless, we'd like to have you share your feedback with us because it's very helpful for us and our efforts. In terms of the survey, we just need personal information, which includes your name, your age, your gender, and the role that you have at your institution today. And the information that we require to be able to carry out this feedback process is to understand what organization you work with today and the country that you are joining us from. So you can see here that this can allow us to move forward and share the next portion of this. So let's, excuse me, Felix,
Félix, si puedes
can
darle
you zoom or expand the survey there?
al
Very
explorar.
good.
Eso, perfecto. Muchas
As
gracias.
I was saying, the survey is in Spanish, but we also have the English translation included to facilitate the process. Now, most of the questions are very simple. We have two types of questions. We use a scale that uses the criteria ranging from totally in disagreement and totally in agreement. In basic terms, what we would like to know is whether or not what we are presenting and whether or not what's contained in the documents, that is extensive information, will meet the expectations. I mean, when we talked about what Mai and Francisco and the other colleagues said, the idea is for this document to be a living document that will be adopted or adapted rather, and that will experience an evolution based on recommendations. We want to make sure that it's as useful as we believe it can be, and you will tell us whether or not we are meeting that expectation. So if you look at the chat, we see that the question was asked as to whether the questions are in English as well, and the questions are translated into English as well. So many of the questions require a yes or no answer, but let's review some of the questions. And we want to ask whether or not you consider these recommendations or interventions mentioned in component 1 is useful for the practical implementation of digital tools for ESAVI surveillance efforts. The next question is whether or not you consider useful the documentation or the reference documents mentioned in component 1. The third question relates to generic persons, which was mentioned by Juan Francisco in his discussion regarding component 2. We want to know whether you believe whether or not this is useful for the development of these digital tools. We also want to know whether you consider that the data structure used to describe the generic people is sufficient to interpret the roles correctly. And in case one of you made notes in your considerations as to whether anybody was left out. Now, we also have a question here that allows you to elaborate your responses or elaborate a little bit further on your responses. And so this will be available throughout the course of today's webinar, but this, as well as the rest of the documents located in the folder on the Drive site, will be available for the next 2 weeks. So the idea is to ascertain whether or not all of the country representatives consider this tool, this approach sufficiently adaptable for your purposes. So if you have any questions, please submit your questions or comments through the chat. Now let's go back to the program. Very good. Let me share my screen again. Can you all see my shared screen? Yes, we can. Very well. Component number 3. As part of the kit adaptation, the adaptation kit, we defined component number 3, which relates to user scenarios. Now, this is a hypothetical narrative. It seeks to consider or identify considerations between different users, different roles, when treating a case or when providing follow-up care or a case related to ESAVI. This isn't just a single thing. The idea is to include as many components as necessary, typically 3 or 4 in each scenario. But the idea would be to include as expeditiously as possible how an ESAVI is being managed, how it's being tracked through the different actions and the different people that are involved. And so everybody's involved in building the story, the narrative behind any particular ESAVI case. So typically we start by identifying and defining the key stakeholders in the case, in the narrative. The narrative as such isn't necessarily a draft, but we do have some data here that we need to enter. We also have the business processes involved in this particular narration. So what do we conclude here? Data, for example, whether or not a person shows up with a potential ESAVI, we need to identify whether or not they were vaccinated. We have a case here involving a 68-year-old woman who arrives at the facility to get immunized for X disease. And what happens is that she experiences an adverse reaction, and we're trying to find out what's happening with her case. So that's the narration. We highlight in different colors the key points of this narrative. Then we move on to the decision logic support. And at the end of the day, we want a clear-cut idea as to whether or not the person is arriving for care with a mild reaction or a severe reaction. If the person is then hospitalized, we have to ascertain what measures we have to undertake to provide care for her. So we would need to classify the ESAVI case as severe. So this type of narrative or this type of event needs to be created, and it needs to be in our system in a standard format so that we can conduct a necessary analysis. We also need to address the capability of the systems and whether or not they're functional. In this narration, we see a 68-year-old person who shows up at the facility for a vaccine against the flu. There's an adverse event with the fever, edema. She goes to the healthcare facility. We would need to identify that facility. We assess whether or not she meets the criteria as for a classification of mild or non-severe ESAVI case. So we have the primary notifier that will assess this on the spot. We do enter some data and we assign an identifier to the case. So all of this narration ends up in the decision to hospitalize the person after a certain number of days. A lot of the symptoms subsided, and the person was then subsequently released. So there are a number of events that are identified in this narration, and this is very useful. For these scenarios, we concluded the data that needed to be collected, the different actions that were functional or non-functional. Then the adaptation kit identifies 4 usage scenarios. The first 3 have to do with the direct intervention with the person or the patient and the evolution of their case. First, involving the interpretation of ESAVI detection and notification. We have a case of an elderly patient that arrives to receive the vaccine, subsequently experiences a mild reaction, and she then worsens. So we have a subnational and national case management considerations. The subnational ESAVI representative investigates a case reclassified as serious, validates data, identifies inconsistencies, and requests clarification. All of this is included in the narration. We also have other types of cases where we assess the causality assessment of an individual case of ESAVI. The Vaccination National Committee validates a severe ESAVI case for causality analysis. And we need to make sure that a certain group meets the criteria and requirements for the case. The National Committee reviews clinical, epidemiological, and vaccination evidence, classifies the event as a programmatic error. It subsequently issues recommendations to approve supervision, protocols, and training. All the information is recorded in the system, and all of the parties involved are subsequently notified. So this is done in a summary. The fourth case, or the fourth user scenario, involves the analysis of ESAVI surveillance data. So what happens is that this operates along a different path. If you see that part of this procedure involves an investigation, a complete investigation of an ESAVI case, but it requires a data analysis component. We need to analyze data to be able to conduct a complete diagnostic of all of the cases, whether or not it's an isolated case or whether it involves more people. We cannot just merely focus on the situation at a local level, whether or not this has other areas in the national area. Nevertheless, there are some cases involving adverse reactions that are not necessarily severe, that don't require such a rigorous investigation. But nevertheless, the analysts can still make note of this because they're going to be collecting information about these cases, and a determination can be made after assessing a series of adverse effects as to whether or not there's a larger scale outbreak or a larger scale impact involving more people. So it could be that this simple notation can lead to the discovery of many more cases. And this is part of an analysis that operates independently of each of these particular cases. So this is not necessarily connected to the natural flow, of an ESAVI patient processing. Component number 4 relates to business processes and workflows, and it's a set of related activities or tasks that are performed together to achieve the objectives of the health program area, such as registration and etc. The business processes are identified as ESAVI registration and notification. We see a natural sequence here when we look at the natural flow here. First, we start with registration and notification. We conduct an initial assessment of the ESAVI notification. We research the case to ascertain whether or not it's a mild or severe case. We enter, or rather, we collect all the data. We assess the report of the investigation or the research. The research generates an additional document, which is the report, and that usually includes much more information than the original notification. So it's an in-depth investigation or research of the case, and then we have the subsequent report issued. We then go to validation and complementation of the research report. We prepare a case file. After that, we then prepare the data analysis report, as we mentioned previously, and then we conduct a causality assessment. The structure of these business processes and workflows, we see here on the table that we use a letter to identify each one of the processes, the people involved, the objectives for the process, and the subset of tasks that are related to this stage. Now, this diagram can be a bit complex. It's the simplified version of the natural ESAVI processing flow. There's a national stage, a subnational stage, and then there's an institutional and subnational stage, whereby all clinical facilities and hospitals participate. And the focal point here for ESAVI would be directly involved in all of this, as well as the notifier. This notification and registration stage acts independently from the rest of the system. We will be addressing this in greater depth later on, but the idea is that we need to understand that we may not have access to internet in some national systems, and that's why it's relevant for us from a functional standpoint that in those cases when we face this reality, we need to have a system that operates independently at the local level with the necessary capability for data entry and the subsequent connectivity capability. And in this way, the information can be passed on to higher levels.
Then it moves to the subnational level, where the research is done, an investigation, and then assessment of the evaluation report. And from that, you move on to the national level, where there's a validation and complementation to the report by the various experts or team of experts. Then there's the preparation of the case file, which is in the hand of the National Safe Security Committee. And then the preparation of data analysis, which is in the hand of the analyst, but validated by the experts or pharmacovigilance or epidemiology reference points. And then the causality assessment, which is provided by the feedback from the experts. And the Safe Vaccination Committee determines the final classification of the case. As I was saying, the idea is to have an offline application, first of all, at the institutional level. Then if you follow the flow chart, you move down to the level of the evaluation committee, which then determines the classification of the case or cases. The notification process, if we click twice and go into greater detail on the notification process, we'd have the following tasks. One is clinical care and communication with the patient, where you get the first information directly from the patient who had the adverse reaction. Then you determine whether the notifier is the appropriate person. You have whether it has the necessary skills to do the report, and through a digital form, it would be filled either by that person or by the focal point. In the case of there's an emergency care that has to be provided, the person receives the report from the health staff, but the notifier is a person who has been properly trained to fill out the form and notify the ESAVI. That's the person then that fills out the form. But if it's a primary notifier, then he should be supervised by the focal point. So that this person then has the function of prioritizing cases. A case that leads to death is not the same, for instance, a case that just gets red spot near the vaccine. And then they determine whether the case is a valid or not valid case, whether it needs more information, complementary information. In that case, it's validated, and once it's validated, it moves on to the next level. Here, now, let me call on the next speaker, Felipe. Yes, thank you, Juan. We're not going to go into the details of each of the processes, but the idea is that once the notification is made, and I think here it's important for those who develop digital tools to make it clear that digital tools should not be designed exclusively for the support of the notification process. There will be other processes that come after the notification that also need to be supported by these digital tools. Here, for instance, you see the task of a subnational reference person, the person responsible for ESAVI. It could be a department, a province, or a parish, for instance, in the Caribbean English-speaking countries. And these people receive a notification, and they must evaluate the notification and then undergo the process of complementing or adding the information or identifying the notifying institution or the person responsible for the notification to improve it in the event there are problems with the notification. This process can be supported by a digital process so that it shows a list of cases or certain functions that would support the process to move it on to the subnational level. Once the case is evaluated, we then proceed to the investigation process. Unlike adverse reactions with vaccines, this requires interaction between the National Immunization Program, those who do epidemiological surveillance, and those who do pharmacovigilance in the national system. That's why in the center, you see 3 lines of work to capture information, to investigate an ESAVI, generally a serious ESAVI. You need, first of all, clinical information about the event. You need epidemiological information and information about the vaccine and the vaccination process. As a result of the capture of the information by many actors, then a research report has to be prepared. And here, digital information tools can help make the process much easier. We have examples in the region where digital tools support information provided by many different users and from many different sources of information. Following that, once the investigation process is completed, there has to be an evaluation of that research report on the quality of the information that has been recorded. Usually, this investigation report has different levels to it. You have the investigation of the first project. These are the tasks of the subnational group where they evaluate and further complete the information coming from the original investigation. Next, here you see that the report is then reviewed by a national level. Here you see that once the national level receives the notification and the information about the investigation, who has the responsibility of completing additional information for that report? Their task is to validate what has already been written. It's important to underscore the intervention. That's why you see three different lines here, three different bands. When we describe the process, there's one band for the national immunization process. There's a separate band for the national authority. It has the National Center of Pharmacovigilance. And then there's a third band for those who intervene from the perspective of epidemiological surveillance. You need to mention current scenarios in the region, for instance, outbreaks of yellow fever, where you identify a suspicious case of yellow fever reported as an ESAVI case. In other words, a patient that starts with symptoms before vaccination and then have active interaction between those who do epidemiological surveillance and those who do pharmacovigilance. That communication is crucial. This can be done through digital tools, and here you can include in the process that interaction. Also, they could communicate with those who coordinate the immunization program, who review the traceability of the biologic product and the process for administering the vaccine. Next, once you obtain all the information through the interaction of the various actors, a case file is generated, and this case file will be used by the Safe Vaccination Committee, who will use the process suggested by WHO and adapted by PAHO for the region, where they will analyze the causality. They look at the report on the event, look at the possible causes for the event, and they must take into account environmental risk factors, epidemiological risk factors in the community, factors relating to the vaccination process itself, and all the activities surrounding the handling and use of the vaccine. So in this business process, you can see the various tasks that will be carried out in order to be able to prepare the file that will be reviewed by the National Committee. Next, as part of or rather as a contribution to the information generated about the event, there is a process that runs in a parallel fashion. That is the data analysis of the National Pharmacovigilance Database. It's very important when there's a single case of a specific disease that occurs right after vaccination and is presented as a serious case, and which on certain occasions can lead to death. It's very important to review what has been the behavior of this event at the national level, analyze the event data, and even have the possibility of doing an analysis of other indicators if the country has, and determine whether the country has sufficient data to apply an analysis, very much more complex analysis models. The data analysts must have very close interaction with the national level and the immunization program with whom pharmacovigilance takes place, and with those who do the pharmacovigilance to help in the interpretation and to help determine what kind of analysis should be done to observe the behavior of the event. So there has to be interaction between the data analysts with all the different levels, and that interaction can be made easier through a digital tool. Next, the preparation of the data analysis report. It is delivered to the case file, and it concludes with a presentation before the National Safe vaccination committee, who will have the responsibility of doing the causality analysis by reviewing all of the pieces of evidence that has been captured and collected throughout the whole analysis process. When you analyze the notification, the analysis of the epidemiological investigation and the vaccination process, and the pharmacovigilance and the clinical process as well. All of that information is put together in one single file, which is then evaluated by the National Committee, and they apply the steps of the causality analysis form, and they follow the checklist where questions are asked that need to be supported by evidence that appear in the case file. And they apply the algorithm suggested by the World Health Organization, and then finally give it a classification or several classifications according to how the methodology states. And the final result with an opinion on how the case should be classified, where the independent committee expresses its opinion on what is the origin of the event and makes recommendations on how to mitigate the risk if they should identify a risk related to the use of the vaccine or the product, or a risk in any part of the process for handling the vaccine in the National Immunization Program. Next slide. Here, the complement the data analysis process by including the final classifications for the event made by the National Committee. This should become part of the national statistics. The information on how the serious cases have been classified in order to close the case, and as part of the record that should be kept by the country. That information itself should be analyzed and compared to retrospective information that has been obtained throughout the various preceding cases. Next. We also should add that the data analysis itself, as you mentioned, has additional complexity to it, which is different aspects to it. You have to have a time analysis, social demographic analysis, that notification analysis, application of quantitative methods. It's a very complete descriptive analysis for the final report. That's why this diagram seeks to reflect the different aspects of the data analysis. It's not very simple, and it's something suggested by PAHO and WHO as well. Next slide. Felix.
¿Listo, Félix?
Felix. As I was saying, the idea is to help us in this webinar to complete the information. If you can't do it now, the form is available. And I'd like to we have already updated the list of countries and territories. So if any is still missing, please let us know. As I was saying earlier, the idea is to obtain your feedback on the presentation as we move forward. Right now, we will be evaluating components 3 and 4, which Francisco and Felipe just presented. And the idea is to find out about the user's scenario. Do you think that the format allows you to understand what the applications created by PAHO and WHO are being used for this purpose in your country? And the next question is, and this is an open response, do you consider it necessary to have other user scenarios in addition to those mentioned in component 3 for greater understanding when carrying out a practical implementation of digital tools for ESAVI? Oh, somebody says, could you put the presentation on screen? Yes, it is on screen. It's in the link that we put in the chat earlier. but it is up here on the screen. As I was saying, from the presentation of this process, we can obtain different information that would be useful to help us model surveillance. What other useful information do you think can be obtained from user scenarios? Again, the question is, and this is an open-ended question, in addition to the data that we just provided, do you think that any other information could be obtained for this surveillance process? Also, in terms of the business process, do you consider the description of the business process presented in component 4 to be useful for the practical implementation of digital tools for ESAVI surveillance? And my final question is, do you think, could you describe a business process in addition to those mentioned in component 4 that are useful or necessary for the practical implementation of digital tools for ESAVI surveillance? And finally, do you have any comments about components 3 or 4, comments or suggestions? So maybe this is the time, if you have any question about this, you do so in the chat. Otherwise, we'll move forward, and I'll call on Francisco. I am putting in the chat the direct link to the presentation, to the full document. Again, keep in mind, this is just a draft, because the idea is to hear your feedback and make it a better document if possible. I've put on the chat the presentation, and it's in English and Spanish. It's in English as well in the other file. Well, if it appears in this link, I'm not going to have to share it. It's been shared in the general file that we shared earlier. Well, let's go on then. Okay, well, I'm going to share my screen, and we're going to move on to component number 5. Component number 5. So 5 is the basic data elements, and it's in English, it's core data elements. And this is the basic data elements or core data elements that we intend to use in ESAVI's national surveillance. And there are 3 elements that trigger or generate data. There's first the registration and notification of an ESAVI, then there's a research or investigation, and then a causality assessment. Regardless of whether there are other intermediate processes that take place, as we saw earlier, but what creates the most amount of data are these 3 events. And these are the ones that are reflected in an annex that accompanies the digital outpatient report to report data which, according to the strength of the data system in the country, that it be automated. The data appears in the following way. There's a form that summarizes the data, and the data are classified and grouped.
So if we look at the different columns, we see an activity as part of the workflow. This relates to the component assessment. And these components have attachments with much more detail, and you can conduct an evaluation. So, for example, if you have an activity, you can enter all the data for the activity. You can label each one of the data points. You can describe each one of these data points. example, the date of birth of the patient, the ESAVI data related to the case, the name of the ESAVI code. And the idea here would be to attempt to standardize not just the data form, but the content thereof. And we refer to this as the semantic standardization related to the data. So all of the data are structured in this way. But if you will allow me a brief moment, let me try and show you the complete attachment. It is somewhat complex. We have other columns that allow us to structure the whole narrative. And this is important for technical people, for those of us who are intimately tied with the software development and that need to know how the ESAVI procedures are managed and how we deal with these issues. Sometimes we have some problems and issues with software development related to how to represent the data. And so providing this kind of structure to the data suggests that the data for an ESAVI report that details the circumstances of a case can be represented in the system through unique selection or multiple selection with what types of characters, or rather data, number of characters, a Boolean form, whether it's false or positive, the date time, the identifiers, the catalog of terms. All of this makes a huge difference when we, especially when we compare it to the manual. The regional surveillance manual has certain attachments and forms, and among them, these forms, which can be very useful when the system is not yet digitized, but we are proposing some additional steps. We can see down here all of the data that we suggest a notification for ESAVI cases should contain, and this is something that needs to be included for any investigation or research. Some of these data are already codified or use certain terminology. Nevertheless, when we try to implement the system, we cannot restrict what we do to these. We have to allow for each country to be able to adapt their reality to the elements contained in the adaptation kit. We can also prioritize certain elements that are used more frequently. Some countries might want to prioritize certain codes. In some cases, when we deal with laboratories, there is other data that needs to be considered. So we want this to be a part of the structure and a part of the adaptation that this data set can be subjected to. You can always keep in mind that the more standardized these data are and the more we adhere to the international terminology, then the more we will facilitate the subsequent processes. This offers the benefit and the virtue of being shareable with other countries where we already have a definition of how data should be shared with PAHO, and we will be talking about other implementation elements later on, but the idea is to standardize all digital systems and include the catalogs of terms that afford the system a greater and better structure and more compatibility with other systems. So that's the point of this annex or this attachment. In addition to the classifications, one would be to identify the case data, the patient's data, the identifier, medical background of the person vaccinated. We need to see whether or not there's any history that could be related to the reaction with, for example, prior diseases, baseline diseases, or other conditions. Any pharmacological history, there may be suspected relationship with a medication taken by the person, and whether the patient is pregnant or not. The data related to any registered vaccinations prior to the ESAVI. So we would need to consider all of those vaccines as well as those outlined in the ESAVI framework. So we suggest using terminology to represent the symptoms and the diagnostics. We want to identify the ESAVI uh, initial date. We also need to identify the vaccination location, the lot of the vaccine, or the manufacturing lot of the vaccine, and what have you. So this is all part of the research and the causality assessment. So all of this is data that is complementary to the overall effort. And the greater the detail, the more effective the information will be. In this structure, we also suggest identifying calculated data. For example, we identify the age when we start assessing the symptoms, the age on the date of vaccination. We need to assess whether or not the case is mild or severe. For example, the ESAVI, as I mentioned previously, severe ESAVI can be classified as severe based on some rules incorporated into the software development. So we could say that the ESAVI, based on the parameters indicated in the regional manual, may require hospitalization, may have as an outcome related to such as death. But the idea would be to automate the decision in such a way that these various fields can be filled in automatically once we get the classification for severe cases. So in those cases, the idea would be to engage in some basic calculations to make some predetermined decisions. With this, I yield the floor to Felipe.
Sí,
Yes,
hay
this is very important and it's
ciertos cambios
very specific to these guidelines and they
ciertas
relate to
recomendaciones
recommendations
sobre la implementación de elementos de
on
datos de que
the
requieren
implementation of data
estandarización y uso de
and the
terminologías
use of specialized
específicas.
terminology.
Un
One
ejemplo
of
de
this,
esto es la
one of these
estandarización de las
examples is
vacunas
the standardization of
para
vaccine
determinar la eficacia
identification.
de las vacunas.
It's
No es
insufficient to
suficiente
just have
solamente con tener
catalogs
catálogos creados
created
propiamente
by those
por
who are
quienes están
developing
desarrollando
the
o por los programas de investigación.
immunization programs.
Es necesario que el
Instead, it's
concepto
necessary for us
de
to
los elementos de
understand that
datos a
the
implementar
data related
debe
to vaccines
tener o ayudarnos
need
a
to
la
be
interoperabilidad o
useful for the
interoperabilidad de las
interoperability and the
informaciones y
exchange
eventualmente el
capability
intercambio de
between
información a
systems
nivel
at the
internacional.
international level.
Los
The
elementos de datos de
features to be
identificación
recorded for the
normalmente
vaccine
se incluyen
that are included
en la,
as
como clase de
essential
datos
data elements
es
include the trade
decir, el
name, the
nombre de
generic
vaccina,
name, the
nombre
descriptive name,
genérico, nombre
the vaccine
descriptivo,
identifier,
identificador de
the marketing
comercialización,
authorization holder,
información de
power,
comercialización, potencia,
pharmaceutical form,
dosis
and batch number.
farmacéutica y número de
It's
lotes.
very
Es
difficult for a
imprescindible que
notifier
los
to have
notificados
access to all
tengan
of this
no
information or to
tengan o
know all of
conozcan
this
todos los
information at the
elementos al
moment the
momento de dar la
notification is
decisión.
issued.
Por
And that's
eso
why
es
it's
necesario
necessary to work
trabajar
and see
por la implementación
about
de estándares
implementing
que
standards, in this
integren
case,
estándares de
pharmaceutical
comercialización
standards
que
that will allow us
permitan
to link
digitalizar piezas de
data
información
items that we
que
can get
tenemos
at the
a nivel
primary level
primaria con
with
piezas de
other
información que se
data
encuentran en
elements that are available
dispositivos de
in
datos
the standard
digitales.
framework. Next slide, please.
Por favor. Es así
This is
como
how
se
these are
menciona
mentioned in the
la
description of
utilización de
data
estándares de
elements,
datos.
the use of pharmaceutical
Estándares
standards.
farmacéuticos.
One
Un
example that
ejemplo
we have at the
que
global level
tenemos a nivel
is the WHO
global
drug.
es el food
This is
drug.
a
Es
standard
un estándar desarrollado por
developed by the
ESAVI
monitoring center that
que
contains the
contiene
links
los
between
elementos,
these
uno de
different
estos elementos
information
son
or
los
data
bits
elements.
que
Somebody that
eventualmente
notifies an
identifican
event may
únicamente
only
puede
have
tener
two
solamente dos piezas de
data
información, un nombre genérico de la
bits,
vacuna y un
the
nombre
name of the
comercial.
vaccine and perhaps a descriptive name.
Detrás de estas
And the idea would be to
informaciones
link
básicas, lo que
these
tienen
two data
adicionalmente
elements
son
to
otros
other
objetos,
data
y aquí
elements.
en la figura
So
de
you
la
can
izquierda
see
se
here
ven
on this example, the different elements that could be linked to the manual. I could have a drug code that's linked to a trade name. I could have a name or an ingredient that is active in the product or an active substance that's also linked to that drug code. And I can also have other associated elements such as the pharmaceutical form, the HCT code, and other health registries. I don't need to have all of the, or well, actually, we would need to have all of the, we wouldn't need to have all of the elements to be able to identify the product, but a few of them can get us to the complete identification. This helps us not, or this keeps us from having to invent new trade names or commercial market names for these products, but rather we can recognize standardized names that have been reviewed by specialists and experts. Who drug is not the only standard at the global level. We have an ISO standard issued by the International Standards Organization that works on linking, or rather developing standardized catalogs for these types of products. The IDMP contains a number of standards and individual standards that attempt to save a great deal of effort for us to have to catalog our products, and by extension for us to try to undertake our identification process. And they make it very convenient for us to be able to properly identify something. So in our different countries, we may have different systems whereby pharmaceutical products are registered, but they need to think of ways to implement and use these international standards that apply to those same products, and they will have to identify the process to integrate these standards into their IT systems. This is not the only area in which standards should be used. Next slide, please. When we talk about registering multiple events that can be notified as ESAVI or as an adverse event, it's also necessary for us to see how we can standardize that information. Now, we need to get away from the use of limited catalogs that generate bias in the information related to adverse events. Instead, we should think about using terminology catalogs or terminologies that are much more comprehensive and make it easier for us to record information, and makes it easier for us to conduct data analysis and allow us to generate a great deal more information from our efforts than having to waste time on trying to identify these products. The guidelines, in the SMART guidelines, we have some elements, the basic data elements that need to be included. We have the C11, we have the name of the event, and the ATC. The country needs to have a discussion regarding the best standard that it should implement, and there needs to be an extended discussion related to the application or use of these standards from the technological standpoint. It's important to clarify that this is not an exercise for developers, and it's not just limited to establishing a standard and including it in the notification forms or in the research reports, but it also needs to consider the model for the database that will incorporate the standard. And it also involves updating the standard, and it should include the data analysis aspect of the SMART guidelines. So this is something that we discuss at length in the SMART guidelines, and the developer that's involved in the process can adapt to these considerations in a much more expeditious way. Next slide, please. Very well then. Regarding component 5, we have the basic data elements. We can show you the available attachment or annex. For each data set, we suggest a certain glossary of terms, and we discuss the terminology available to be able to work with those basic data elements. Now, moving on to component 6, decision logic support and programmed logic. It's worth mentioning that programmed logic is determined by the SMART guidelines in general, seek to document the procedures that need to be undertaken automatically or in a programmed fashion based on certain elements. For example, batch processing that we carry out at certain times at night or that are run once a month or once a week, or that trigger based on an event that is particularly unique. In this case, we don't identify programmed logic as part of the process, but it is nevertheless important that you consider the assessment. Perhaps in your experience, it might be convenient to conduct other calculations and other programmed logic and use whatever is done in your own country, whatever you consider to be appropriate. But in our analysis, we did not identify any specific program logic, but we did identify a number of decision logic. Now, these foster better decision making, and it relates more to the business processes. So these workflows or these decisions are the ones that are addressed in this section related to component number 6. The decisions that we identified are 7 in total, and they are related with the data validation, whereby there's an assessment that should be determined with a minimum data set that we define the patient, we define the vaccination considerations, the dates, and this relationship or this minimal amount of data needs to be in place for us to make the necessary determination. Likewise, when we identify the exceptional nature of a case, then there are certain programmed logic elements contained in the software that will allow for a more expedient notification for those types of cases. Now, we have at the regional level a user's manual that address exceptional cases, the determinations thereof. So each severe case needs to undergo a research or investigation, and there are other cases involving exceptional considerations that would also use this logic that should be supported by the software. And these are the standards that we try to incorporate into this subset of decision tables. We also address the research elements, the identification of an ESAVI event, we also need to determine whether or not any additional actions need to be undertaken. So the decision table structure is as follows. We see a unique identifier. We describe the general business area. If the data are not valid or consistent, then we need to reject the registration for this new ESAVI because it lacks the necessary data elements. This is very simple here, but the idea is that by having these different types of logic in the adaptation kit for national use, we can create a workflow in the software that will expedite and make things easier. So we're using the business logic and transitioning to the programmed logic.
It has direct correspondence to what has to be done. But if there are no valid vaccine data or patient data, then you need to generate a guide so that the user knows what he's going to have to do before he moves on to the next step of the flow chart. And here you have Felix now, who will give us feedback on components 5 and 6. Felix? Thank you, Francisco.
Gracias, Juan Francisco.
Yes, there
Sí,
is one
efectivamente,
comment
hay
in
un
the chat
comentario en el chat
that
que
says
dice que
that it's difficult to
está difícil
do
hacer la
uh,
evaluación
evaluation
que recién estamos
on the
viendo.
spot
Y
as we're
efectivamente, como
looking
se
at it.
mencionaba también,
And as I
vas a
said
tener
in the
2 semanas
chat,
más
you're going to have
acumular
2
el
weeks to
tiempo para eso.
review this form and
Y vuelvo a
submit your
mostrarles
comments.
los 2 enlaces que están en el chat. Por una
Also,
parte, está este
in this
PowerPoint
file in the
impreso,
chat, you
y
have
por
all the
otro,
documents
el
and the
formulario.
form.
Y esta es la
And
etapa del formulario en la que
we're
debemos
now
estar,
moving
que
on
evaluando
to the
componentes 5
assessment
y
of
6.
components
Eso es
5
lo
and
que acaba de
6
presentar Juan Francisco y
in the
Y
form. And
volvemos a las
uh,
preguntas en esta escala de
here the
Likert,
questions
donde lo
are,
primero es
do you
considerar
think
si
that
ustedes consideran que la
defining
definición
a
de los
data
conjuntos de datos,
set
por una
in
parte,
component
y
5
por otra, este
facilitates the
soporte de
practical
los datos de
implementation of the
decisión
digital
ayudan
tools
a la
for
implementación
ESAVI?
práctica de
And
algunos
do you think
postulados
that
de
that
vigilancia de
definition
decisión.
of
Esos son los 2 primeros puntos.
decision logic
Luego,
is a good one? And
dejamos
now
un
we
espacio
have
para que
also
efectivamente
left
ustedes
some
puedan
space for
complementar
you to
si es que
comment on
consideran que
whether
hay
you
alguna
think there's
necesidad
any
de tareas que
need
se deban programar
for scheduled
para el
tasks
tratamiento de
in
los
the
datos que no estén
processing of
contempladas o no
national
presentadas en el
surveillance
documento.
data. And if
Y si es
so,
así,
please
nos
indicate
pueden
what
indicar cuál y
you
describirla.
would like to have
Y en
training
la
in.
misma línea, nos
Secondly,
parece muy interesante saber si es que
in
efectivamente
the
dentro
process that
del
we are
proceso que
describing
nosotros estamos
throughout
describiendo a lo
this
largo de
guide,
la guía y
particularly
en
with regard
particular
to
en
the
el ejemplo solamente,
components, do
para
you think
incorporar
that
alguna
there's
decisión
any important
importante
decision that hasn't
que
been
esté
mentioned?
mencionada.
As I said,
Como les digo y como les he comentado
in the
en las
various
distintas intervenciones, hay
interventions, there's
espacio al final
space at the end
para
for comments,
comentarios,
but
pero les pedimos
we'd
que
like you to
recuerden
keep
siempre
in
el
mind the
objetivo último
final
de esta
goal of this
evaluación,
evaluation,
que
which
es que
is
podamos
for us to
compartir
be able to
incorporando
incorporate
las
the
distintas
feedback
retroalimentaciones
we've
que hizo
received
la
from
tercera
you on
prueba,
these
que buscan, por
questions. For
ejemplo,
instance, to make
conocer la
sure
claridad
how clear it
o
is
conocer de si
and
efectivamente
to
a la Likert
determine
que
through
ustedes
the
han
work you've
desarrollado, el
done, your
trabajo que han hecho
experience, your
en base a las
realities
realidades
in
del
your
laboratorio,
area,
tienen,
is
por
there
ejemplo,
an
alguna
additional
necesidad
need or a
extra o alguna
decision that
decisión
does
que
not
en el
appear
marco de esta
within
SMART
this SMART
guideline no esté
guideline?
contemplada.
And
Siendo así,
since I've
y
seen
teniendo
there are very
claro,
few
asumo que el tiempo
answers
todavía
on
no
the
es el
spot
momento,
in the
entonces
chat,
creo
I
que
think
lo más
Felipe and Francisco, we can go
consecuencia es
back
que
to the
volvamos a la
presentation.
presentación. Hasta el
So
momento
far,
tenemos
we've
4 preguntas con
only
4
had
respuestas
4 complete
completas.
answers, and I'd
Le
like to
agradecería
thank
a los
those who have filled them
cuestionamientos
out. But for the rest of
y a
you,
los que no
I'd
les
like
pedimos
to
que
ask you to
luego
please
puedan seguir
continue
revisando la
looking at the
información del
form
libro.
and fill it in
Así que
as
creo que
you
sigamos, Juan
have time.
Francisco. Cambio.
Yeah, we did realize that this was a much more difficult section to provide feedbacks on because these are very, very technical components. We're now getting to the very end of the digital adaptation kit, and it's very complex the data sets. We're going to be looking at performance indicators. These are much more difficult, harder data to respond to on the spot. As somebody just mentioned, it's harder to give feedback because it requires more analysis. But if any of you right now have with using your clinical eye have a comment right now, please do so. If you say there's an indicator that's missing or a decision logic that's missing, please go ahead and share that right now. Now, component number 7, performance indicators and metrics. What we're seeking through this component is to define and support countries that want to implement a more active surveillance system more so than ESAVI. What are the indicators that can help determine certain decisions or are relevant for the business? So you have to define a structure that uses as a basis the guidelines, and you then have to define the kind of indicators you want to give them a name, a definition, so that we can better understand the case. in these case, we have the ESAVI notifications for every 100,000, a description of the numerator, a description of the denominator and its calculation. In this case, there may be some indicators that may not have a solid denominator. They only have a numerator. For instance, there could be a count or a listing of data. There might be just a number for the number of cases. And then you have a breakdown and a reference. The breakdown is very important because, or disaggregación as it says here, but breakdown may have different indicators, but it may be the exact same data handled in a different way, but it may have different metrics, for instance, or different filters. For instance, I can filter the same case of a rate of the ESAVI notifications and break it down by age or by sex or by whether the person is pregnant or not, by geographic location or by type of vaccination or vaccine. So that's why it's very relevant to have, important to have codes for all this. That's why these are dimensions of the same indicator. These are filters, screens that allow you to do a more exhaustive analysis of each one of these cases. And then finally, at the end, there has to be a link back to the background that'll help us define this indicator. Here, you may have some indicators that have already been defined in certain PAHO or WHO documents. So you have a label of indicators. Here we've listed 15, notification rate, proportion of adverse cases or ESAVIs based on clinical events, for instance, anaphylaxis or any other adverse reaction to the event, the clinical event. And then the breakdown of ESAVI by clinical group, when symptoms started. In other words, how long did it take to have an adverse reaction? Because as we know, there are many cases where there's a reaction to the vaccine made by a certain manufacturer. In the case of influenza, on average, the reaction time is 3 days or 4 hours or whatever. This one may be different. So on the basis of ESAVI, how long is it taking to notify a ESAVI event? The acuteness, serious, not serious, toxic, topsy in the case of a death. All of these indicators appear here, and in the guideline itself, there's a lot more information. For those of you who are interested in data analysis and those of you who have more experience in the field, knowing exactly what may lead to more exhaustive analysis, say, for instance, a batch, the vaccines or question how the vaccine was applied, etc. All of these are indicators that should be included. If you think this list is too short or too long, please comment. And then component number 8, there are functional and non-functional elements. And this, people who are more involved in software development have better understanding of this. It's a typical tool used by software developers, which is used by the user record or history. Through certain titles, you determine a history that narrates and complements the rest of the narrations about the user. In this case, as a primary notifier, I want to record and locally keep data on a new ESAVI case. This record can be notified. So this way, I can fill in the data at different moments in time, make sure that it meets the minimal necessary standards, etc. With this structure, we can document 74 national requirements, which is fairly long, but each one of these has a subset, and it seeks to represent functionality within the system. That's why it's called a functional requirement. That we also documented 116 non-functional requirements. Many of these are tied to other digital outpatient kits that have been published earlier and are related to different categories of non-functional requirements. For instance, one is safety, the other is the response time, etc. Configuration. So there are different classifications and categories for these non-functional requirements, and there are many. And I'm sure that in the public there are people who develop software who may have some feedback to help this more specific. Maybe you could say you need to add something else, or this is redundant. This is what we have to say about the non-functional requirements. I don't know, Felix, do you have a comment on this? Felix or Felipe? Felix. Well, let me go back to the form. Now, what we need to know in terms of the structure that was just presented by Francisco, the structure of the indicators and the functional and non-functional requirements, we'd like to know how useful do you think they are to help you understand and move forward in the processing of ESAVIs. And another question is, we would like to know whether, independent of the functional requirements presented in the doc, do you think it's necessary to add any others or make any changes to the ones presented? And then at the level of the non-functional requirements, the same question applies. In other words, in addition to the ones that Francisco presented in the list, do you think any others need to be added? And finally, and with this, we complete the review process, and I'll give the floor back to Felipe so that we can move on to the next phase of the webinar. With this, we complete the feedback process. And again, we'd like to express our appreciation to you for doing this now during the seminar or over the next 2 weeks, because your feedback will make sure that we have a document that the countries really need and want. I think there's one more part of Juan Francisco's presentation that needs to be covered, which is the guideline on implementing FI. Do you hear me? The guide on the implementation of FHIR. But before I complete the review of the digital adaptation kit, let me give you some annexes. There's 4 annexes. One is the dictionary and data elements that I mentioned earlier. The second annex is Annex B, and that's the decision lodging support. One, can you make it a bit bigger because we can't really see it? Enlarge the screen. I realize that you don't want us to read it, but at least enlarge it so we can see it. I just would like to put this up so that when you read the document, you know this exists. Can you see it now? Should I make it a little larger? There. That's good. So the data dictionary as classified by notification and by 3 events that lead to this. Then the decision logic support, and there's different tabs for the decision table, the decision that I explained earlier. On the other hand, there's also Annex C. Oh, I forgot to mention Annex C. Annex C is one for indicators. It is a group of 15 indicators. with the description of each one, and each one its own breakdown and reference of how it starts. Also, it's important to note that these indicators could be related to other data that can be extracted from other systems, and I'll mention that later. And then the functional and non-functional requirements, which have been presented or grouped according to the event, was a notification, individual evaluation, research, investigation, etc. Each one leads to certain functional requirements. And then you have the non-functional requirements. They're also categorized to help the reading this and reading the paper. So here you see security and confidentiality, audit, user, scalability, interoperability, configuration, hardware, again, guidelines. So this document, it will also be available. In fact, it is already available for your review. And I'd like to conclude my presentation with a description of level 3. Level 3 refers to the guide for the FIHR implementation. FIHR comes from a standard that is used for interoperability of health systems. It's fast health interoperability resources, and this helps facilitate interoperability of systems. And for this, it establishes structure, and it states that when you're generating a platform or creating interoperability between systems, you need to create an implementation guideline, but on a website, but not just any website. There's a specific structure to it, and it determines the rules for sharing the data. This is the implementation guide that was created for implementing ESAVI. It has a description, certain objectives to define the problem. And then one of the important points is that it proposes interaction between different systems. So what it seeks to do is that since there's so much data managed in surveillance, it be divided according to it can be automated, and the loading of data on ESAVI be automated. For instance, if you have a system such as being developed in Chile, where it's a system to share medical records and the electronic medical file, there are going to be rules for how to share that data. And those rules will need to be applied to implementation. You have to abide by certain standards and certain technology. So the idea is that these patients' records appear in a master person index or a national person index or another system that already has this data, as for instance, the national vaccination record or NHR. So all that data that's already exists and has been validated and is used by the systems can be uploaded when needed. For instance, I, Francisco Iñasco, have an adverse reaction. Well, there's already a record of me and this immunization. So it's not necessary for the person who's recording or notifying this new case of ESAVI has to insert all the other data. Well, the ideal system would allow it to seek the data in all the other systems, bring it up for that person to use. And the same thing with terminology that is used in representing vaccines, disease, symptoms, medication used, doses, etc. All of that data is already in the system, and if we standardize the terminology, given the maturity of the system in the country, they can include this terminology, not just in the SAVI vigilance system, but in all their other systems so that the data can be correctly implemented. We have cases of use, the artifacts, how it's structured, how you structure each one of the notifications and transactions. Here you have the data referred to the type of data. It's a very, very technical document, but very useful and makes the job of interoperability of systems good.
It's important to mention that we already have this in the implementation guide, whereby you can share data with PAHO, and the ESAVI guidelines already show how to share this, and this includes all of the data sets that can be shared. And it would also be the monitoring center that receives all that data as well. Is that correct, Felipe? No, that would be the responsibility for each country. Each country would have to conduct their own analysis. Very well. The idea is that there's certain guidelines in place, and at a future juncture, once there's an existing national ESAVI registry, then we can create synergies with other cases that are being observed at the global level, and decision making can happen not only at the national level, but also at the regional and global level as well. That's what I wanted to mention regarding the implementation guide. But additionally, I wanted to mention one of the components of the implementation guide that can facilitate the implementation of these regulations for the ESAVI data. Each one of these implementations has an active component that activates the software and facilitates and makes easy the evaluation of said data. For example, if we have a system that is in the middle of the Amazonia that has a certain software, once we have connectivity, we can share the data. But it turns out that the data has to meet certain requirements for the implementation. So these rules are already loaded on the packet that's available for the updating of the system, as long as it meets the rules that are established. For example, the different codes related to the data elements, it has to be related to a prescribed terminology for a vaccine and that sort of thing. So we undertake the process of inputting the data, and we can also share data from these systems to others following the same rules. We can also validate the data automatically. So this rule set requires a great deal of time for the implementation in case these guidelines are not being used, such as the machine readable aspect of it. And so with this machine readable feature, we can facilitate the sharing and the incorporation of new data into existing systems. That's all I have. Felipe, you have the floor. Thank you very much, Juan. Thank you very much, Felix. Just some recommendations regarding the next steps. Let me stop sharing the screen. Clearly, there's an expectation that these guidelines can be very helpful for those who are currently developing digital tools. You don't have to start from a clean slate. You don't have to create a new ESAVI surveillance system. Rather, you need to undertake the development of a process, meeting certain requirements, come up with certain data models, a subset of indicators, potential users, some aids that can help in decision making to be able to program the system adequately. So you don't have to start from nothing. So what can we see? Well, sometimes when you provide the content for some ESAVI cases, then you'll find that there are processes included in the guidelines that don't exist in the country. So in that case, we would need to go back and review the international standards, look at the PAHO WHO recommendations, and then see whether or not we need to undertake certain additional steps for our surveillance system. So we need to assess the capability of our surveillance system compared to the international and regional systems. We also need to think about how we want our ESAVI surveillance system to work based on certain criteria. This is a decision process that we all have to make or undertake. Again, these are recommendations. It's not that each and every country has to do exactly the same thing. There are certain scenarios whereby certain procedures and processes need to be adapted. There are some countries that don't have a subnational level. They may have a local and a national level system. There are countries that need additional actors depending on how their respective healthcare system is organized. They need to consider how they will integrate certain functionality for different stakeholders in their country. This is emblematic of Central American countries where they have social security systems that are linked in different ways with their respective ministries of health. So we need to see which functions apply or don't apply with any system. And so we need to identify those stakeholders that are involved in that sort of thing, and we need to try and adapt to their needs. We see that for persons we recommend, or there's a person that we know as the researcher. Now, the researcher isn't just limited to the function of research. In some countries, they end up being a part of the surveillance team. So many times these individuals undertake the epidemiological research on site. In other cases, they might support the ESAVI research or investigation procedures based on their specialization, and they might do some of this work in the field. And then there are others that have a researcher, an individual person that is in charge of all of this. There are some components that you've seen that do have very strong recommendations by WHO, and that's the analytical process capability for individual cases. The causality assessment aspect is fundamental for vaccines or immunizations, and many times it's triggered by the death of a person. So this might trigger the involvement of national and local authorities, and more importantly, public health authorities. So if our population stops using the vaccination due to any of these events, then we need to engage in a great deal more activities to build the public trust. So we need to come up with a process that can be supported by these digital tools. So in terms of next steps, the next steps would be as follows. First, we would ask those who can do so to review the main document, the guidelines, as Juan and Felix have already recommended or stated. It's the main document that contains all the guidelines. Additionally, where possible, we recommend the review of the annexes. We understand that it's a great deal of information. Perhaps one team can review a certain component, certain specific annexes. We could really improve our efforts with any feedback from you after your reading of the document to ascertain what your thoughts are and what recommendations you have for the organization. Next would be discuss this with the teams in charge of the national ESAVI surveillance. And so if you're in the process of developing a digital tool related to the surveillance, then this template could be very useful. And you could discuss amongst yourselves what the real useful application of these guidelines would be for the development of the digital tool. And this is something that we're currently working on. And the idea would be for us to meet at a later date, discuss the issues, and perhaps we might find things that are not as useful or not as comprehensible.
puede ser un feedback para
And that could
nosotros.
be potential feedback for us, and we can incorporate this into the templates and forms.
Todas las preguntas, ustedes pueden
So
irse a una
you may focus on a
pestaña
particular section of the guidelines,
sobre esas
review it,
preguntas,
and
perfecto, pero
offer
digamos que hay una
comments
sección
or,
para
or
todo.
feedback. Now,
Quizás lo que
it
puede
may
pasar
happen
es
that
que
you
hay una
might find a
sección
section or a component that you
inmediatamente
don't understand very
empieza
well
con un
without the
componente.
presence of another
Entonces
component.
puede
So
que
if I start
si
looking
yo
at business
empiezo a hablar de
processes
procesos de negocio
and I don't
y
have
me
a clear
olvido
understanding of who
de las
the
personas
users
o los
or the
actores que
stakeholders would
están
be, or which ones
en
are
el
mentioned in the
componente
prior
previo,
component,
pues va a
it'll be
ser
hard for me to
difícil
understand that
lograr.
component. So I'll have to go back and read that prior component.
Em,
Lastly, the
Idealmente,
recommendation would be to fill out the
hacer
form and make
recomendaciones. Les
recommendations.
agradecemos cualquier
We would be very grateful to get any
recomendación
or
o
a
muchos
lot of
comentarios y poder
feedback from you.
revisarlos,
This is
agradecerlo.
something that will be very useful for us, and we expect and we hope that this will remain
de la región
in the region for
en punta de
all
pie
countries to
con
use,
las
and it could be a
herramientas
fundamental
para
tool for all
immunización.
countries to be able to improve and enhance their systems.
Sus inputs
The
son
deadline for your feedback
bienvenidos
would be
para
August 6th,
poder
2 weeks from now.
revisar el documento y poder
And we
revisarlo
hope to
con
get your
sus
feedback before then.
Es
It's also
necesario
necessary to
mencionar
mention
que
that
la Organización
WHO
Mundial de
this year
Salud este
published
año
the first
publicó el primer DAC
uh,
de
document
inmunización
on
en general,
immunizations in general. It's already
de las
uploaded to the
emergencias.
website,
Entonces ya
and
hay
it offers some guidelines and
inmunizaciones.
recommendations for immunization efforts.
Esto se suma
This was
a
added
las
to the guidelines that we expect
de
to
remisión.
offer for developing these digital
Agradecemos
tools.
muchísimo
We want to
a
thank
todas
everyone for your patience,
personas y
for
la paciencia.
staying with
Obviamente
us
aquí
throughout the course
una
of
reunión
this
y
meeting.
no sé si
And I don't know if
May
or Felix or
Félix o
Juan,
Juan quieren
if they might want to offer some parting remarks or recommendations. Yes, thank you, Felipe. I don't know if Mai was able to get
ya está
logged in again. Go ahead, Mai. Yes.
Sí, no,
I just wanted to say that we need to capitalize on this opportunity that's being offered by PAHO to comment and participate in this process. This is an extremely important effort, and it is paramount for us to get feedback for those individuals that will be engaged in the development, because this type of technology will make everyone more efficient. So I'd like to encourage everyone to participate over the next 2 weeks. It would be interesting to set up some teams at the local level so that you could conduct the review process by groups. I think that would enrich the experience in each country. So other than that, thank you very much for joining us today, and we will await your comments and
Gracias,
observations
May, y
prior to the
voy a
deadline.
darle la palabra
Thank you,
a
Mai.
Daniel, que
Let
fue
me
el
also
responsable
yield the floor
de este
to
proyecto.
Daniel,
Por favor,
who
Daniel.
managed this project. Go ahead. Thank you very much, Felipe. And thank you to all of the team members, all the epidemiologists and the systems experts and PAHO members and staff that have been working over the last 4 years on promoting and fostering digitization for these ESAVI systems. These came about as a result of the pandemic, but we know that all of the work that has been done over this period has finally crystallized into something that really offers potential for all countries to incorporate their various vaccines and immunization systems. So, this idea that all of these innovations can be applied in a progressive way, not just to ESAVI surveillance within the regular framework, but they can also be very fruitful in the new framework. I want to thank the team at SENS, led by Mike and Felix, and in some measure by Juan over the last year. And all of this has led to us being able to have the first smart guidelines ready, and that we are very proud of. And this would be the first attempt by PAHO, the first of many future ventures that will allow us to enhance our systems. If you access the links that you will find in the publications. That would be one way to do it. But if you go on the WHO website, you can also see that on the website there's discussion about different parallel efforts in other spaces where the digitization is also happening. They are looking very heavily at technology, but they are also uh, focusing on standardizing practices and improving said practices. And they want to do this through the availability of more digital tools that will facilitate all of these efforts. Thank you for joining us today, for staying with us over the last 2.5 hours. I think it's been a very enriching experience. And lastly, again, I encourage you to please send us as much feedback as you can so that in the end, we can provide you the best possible tool to help you in your efforts. Thank you very much. Thank you very much to everyone. I don't know if some of the team members want to stay back, remain back, and have a brief chat after we have everybody leave the session. Thank you to the interpreters for your excellent work. Have a good day. And thank you to the people who have already responded.